Okay, so we had talked about hyperparathyroidism, and we're finishing up. This is now what do you do? This is the post-op patient. And hold on, let me pause you. I have people coming in and I have a loose plug. Hold on. Okay, so I think all the plugs are good. All right.
Before we start?
I'm sorry, is someone talking?
Yeah, can I ask a quick question before we start?
Yeah.
When we were talking about surgery for this yesterday, we said that it was just for the primary and secondary. Why won't we use this for the tertiary disease?
That's a good question, because why? Let's go back to the tertiary slide. 2 seconds, guys. Hold on. These slides could look a little screwed up. Here it is. Okay, so let's go back to primary. So primary we're looking at, this is the organ, right? Primary is always directly the organ. Then we're looking at secondary, too fast, secondary. So this is anything that's going to cause hypocalcemia. Typically, it's your renal failure patient, classic example. But then in tertiary, what's the problem? Surgery isn't going to help this because the problem is normalcy. You know, the body is normal. You have secretion of PTH even with normal calcium levels, which shouldn't be, right? But the body is so accustomed to having been on dialysis and in that state of dependency that even once it's corrected and you get a new gland, it's not working. So, you know, surgery isn't going to work for this as much. Does that make sense to you? We'll probably use the receptor antagonist, we'll use other things, but it's not going to work like it would if you had an adenoma or you had, you know, like an issue with your kidneys that they were so bad we could take them out and give you a transplant and your body would react well. Does that make sense to you?
Yeah, so basically with the first and secondary, removal of the gland is going to fix it because the gland itself is over secreting, and with tertiary, removal of the gland is not going to fix it because the gland's without feedback being involved.
Yes, yes. Yeah.
Right.
Okay. Okay, so where were we now? I'm trying to think. We were on slide. We were down further. We did that. We did this. We talked about that. Okay. Oops. One too many. Okay. So post-op, what are we doing? Assess, assess, assess your patient. You hear me say it all the time. I can't say it enough. So we're watching for hemorrhage. They've had surgery. We're watching for fluid and electrolyte balance. Watch for a sudden drop in calcium. That would be tingling and spasms and laryngospasms. And we keep calcium gluconate available. There's an auto-ject, like it's in a box, it's all ready, it's like in a code, you just screw it together and give it. We keep that by the bedside. Calcium gluconate raises a threshold for cardiac arrhythmias, so it makes the heart less irritable. We're going to assess the, you know, Shabazz-Tech and the Trousseau sign. That's always good to go. Shabazz-Tech's the cheek, right? Watch the INO. It's important. It's important with the adrenals. With the parathyroids. Dietary teaching depends on the patient, what the doctor wants them to do, the severity of their condition, the background, which etiology they have. We encourage mobility always to promote bone strength. That's good for everybody. You know, we always have people up and walking. And we teach signs and symptoms of hyper and hypocalcemia. Now, typically, if you ask a nurse, tell me about hypercalcemia, they'll say, you know, stones, bones, moans, and groans. That's just what they learned years ago. And I kind of tell people to steer away from just mnemonics if you're just going to remember the rhyme and you don't understand the concept behind it. So what they're talking about is typically the stones, you know, increased calcium, you're going to get kidney stones. The bones, increased calcium excretion, you can have bone problems, right? The moans is they get a lot of GI disturbances, so they're always moaning. And the groans is that they have anxiety and depression and all of that that comes with it. So most nurses will tell you, oh, it's, you know, stones, bones, moans, and groans, but it's a little more than that. You got to understand the concept behind it. Then hypocalcemia, you know, are we looking for the drop in calcium we just talked about? So do they have the tingling or the numbness or the tetany or the twitching or, you know, any of these things that spasms and things, any of these things that are new for them? That's what we're watching. All right, so hypoparathyroidism, parathyroidism. We thought the other one was rare. This is even more so. Very, very uncommon because it's usually just a lack of parathyroid hormone. And so why is that? That's like such an anomaly. And obviously it's going to result in hypocalcemia. Now, it commonly is iatrogenic, meaning it's caused by the physician. It's caused by the treatment. Now, they're not going out and intentionally doing this to you, but what does that really mean? Let's say they went to get your thyroid out because you were hyperthyroid, you had thyroid cancer, you had all these toxic nodules, whatever your situation was, even me that had none of that, and the thyroid is coming out. What was one of the things I told them on my list? Leave my parathyroids where God put them when I was born. You know, why? Because they're buried in the back of your thyroid gland. And my case, my gland wasn't big, but picture somebody with a huge boggy goiter, like my brother. So they go in to get his thyroid. You don't want to manipulate the gland a lot. You don't want to leach thyroid hormone everywhere, but you have to go in the back. You can't just take the thyroid out. They're embedded. You have to separate the vascularity, all of that. So they're in there and digging around, and sometimes they cannot find the parathyroids. If the gland is really hyperplastic, lots and lots of hyperplasia, they can't find it. And so sometimes you'll see the report from surgery saying attempts were made to locate parathyroids, and the tissue was so overgrown they couldn't find it. Sometimes they find them, but in the process of digging them out, they damage the vascular supply, you know, so that's considered iatrogenic, even though it wasn't intentional. We're not saying doctors are intentionally hurting somebody. So maybe it was inadvertent. They thought they had 3 parathyroids and the 4th one they couldn't find and they came out without it. So, you know, who knows? So all of that can be an iatrogenic cause of why you're suddenly hypoparathyroid, okay? Now, genetic is a very, very unusual thing. They call it a pseudo hypoparathyroidism, and it's a genetic thing. Your parathyroid secretion is fine, but your body acts like it doesn't know it's there. Very, very rare. Even to find literature on it is difficult. Idiopathic, obviously they don't know where it comes from. They're assigning this to children. And in children that they find this condition in, they see early signs of antibody, you know, parathyroid antibodies. So they can only assume it's an autoimmune disease. They still call it idiopathic because they can't trace it down in research to its substantive cause. Other things are people with heavy metal poisoning. You know, the aluminum hydroxide is one of those antacids that people take, and sometimes they just overdo. So aluminum is one. What else? Mercury, iron. People, you know, think, oh, iron's good for you. And instead of doing it just under doctor's order, they take it and take it and take it. I know people that I used to, when my kids were babies and I'd be in, you know, grammar school, taking our kids to school, and other people had infants, they would say, you know, the doctor didn't order me to have formula with iron, but I saw it in the store, so I got it. And I'm thinking, why are you giving your baby iron fortified formula if it's not with direction? But the thing is, it's out there on the shelf, so they just bought it. So, you know, it's dangerous. So I would say, I would throw it off your pediatrician first. And maybe they say, yeah, it's okay. Do it, you know, however often, or don't do it at all. But it's, you know, that kind of thing can be an insidious kind of heavy metal iron kind of overload. So people go by their own wits and they survive. You know, we do fine, but, you know. All right. So what do you see? Signs of low calcium, we've just talked about them. Decreased calcium, you're going to have an increased phosphate in your blood work, because in a disease state or any kind of abnormality, they go opposite, even though they should track together. And that's good to know because sometimes that's how we treat it, right? I was saying yesterday, if the phosphate levels are high, we give them phosphate binders. We're hoping it'll raise the calcium. Because if you can get one down, you get the other up. We're trying to get them to the middle, very difficult. Tetany, they get that contracted state, you know, tingling of the lips, that's the big one, the big one. Even after I had my thyroid out and they assured me my parathyroids were just fine where God left them. But they said to me the next day, just because we manipulated them, if you feel any tingling or anything around your mouth, just take some Tums. And I didn't have any problems, but they prepare you just in case. So tingling of the lips, stiffness in the extremities people feel, muscular stiffness. Spasms. You can have dysphagia. This is dysphagia with a G, so it's not dysphagia from speech, it's dysphagia with swallowing. Laryngospasms, that's another one. And lethargy, personality changes. People usually don't pick up on their own. It's somebody else that has to witness their personality change. So they're not, the tingling of the lips probably, tetany would draw people's attention. But people can pretty much talk away some kind of dysphagia or upset, or if they're stiff in the morning or something. You know, a lot of these things that are insidious don't draw people's attention. Okay, so what do? Well, we treat acute complications. Certainly tetany, we don't want to keep somebody in tetany at all. We administer IV calcium if we have to, very, very carefully, very carefully. High calcium can cause you cardiac dysrhythmias. They can cause phlebitis. If you have somebody, if this comes in a piggyback or in even a bigger bag, sometimes in a 250, and it just drips nice and slowly. You got to watch your patient, keep an eye on them. If it extravasates, you know, I'm always preaching about you have to have good lines, maintain your lines, make sure your adapted lines flush, that they work. When you need an adapted line, and it doesn't work, what good is it? So when I assess people in the morning, I have all those flushes in my pocket and every adapted line gets flushed. I need to know if I need it in a minute, it's gonna work. So check those lines. If they're old, I pull them. I don't want the patient to get phlebitis and get some complication from that. I don't want a dead line. You know, in an emergency situation, you don't need a line that, well, if you turn it, if you move it, if you shift it, if you put gauze under it, that's a non-functioning line. Yank it and put a good one in there. So if you have a peripheral line and it's not good for some reason, and we're given calcium and it extravasates, it goes out and infiltrates the tissue, it causes necrosis of that area. So you have to be careful with calcium. It's nothing to mess with. All right, the rebreathing is something else we can do. Rebreathing is an unusual thing for people to see, but it works. So what happens is, they will have somebody rebreathe into a bag. You know, you see it sometimes in the ED, and people are looking in like, well, what are they, hyperventilating? What's going on? They'll have them breathe into a bag. And what they're doing is reducing how much carbon dioxide you're excreting, right? So that's going to increase your carbonic acid level in the blood, okay? That's going to lower your pH. That supports the ionization of calcium. And ionized calcium is active form in the body. So that's how that works. And sometimes somebody will just go by and say, they're having that patient breathe into a bag and they're not hyperventilating. Well, they must have calcium issues, you know, and they're trying to ionize some calcium. So everything is done for a reason. And if you don't understand why something's going on, ask somebody. You know, it's better you understand while the situation is there.
Dr. Benetti?
Yes.
Did you say it was active, if that increases active calcium in the body?
Yeah, the active form of calcium.
Okay.
Calcium is the active form.
Yes, ma'am. Okay, I just wanted to double check. Thank you.
You're welcome. Okay, so what else? Watch the cardiac function, the muscle cramping, dysphagia, laryngospasms. You'll see people will have haunting speech and they'll have that intermittent kind of breathing when you have a laryngospasm. There won't be a question in your mind they're having a problem. Teach long-term drug therapy. Teaching is a big part of what we do. They have to take the calcium supplements if they're ordered for them. If that's their source of calcium, they need it. So you need your vitamin D because you can't absorb calcium without it. So those are very important points. And sometimes they'll say, I'm not one into vitamins. It's not about vitamins now. You know, you don't have to be saying that you're the one that hangs out in the health food store and has to try a little of everything. This is now prescriptive. This is for your need in the body. You have to take calcium, you need vitamin D to absorb it. Diet therapy. They might want them to have a lot of green leafy vegetables, a good source of vitamin, but we avoid spinach and rhubarb because they have a lot of oxalic acid and that can inhibit calcium absorption. It's not that it doesn't provide calcium, it's not going to let you absorb it in the body. So there are better choices. People take spinach maybe for iron. It's probably good for iron, not so good for calcium absorption. So they got to come back for lab checks. This requires compliance on their part. It requires follow-up. This is just part of it. They can't say, I'm done, I'm out of the hospital, I don't want to deal with it anymore, which some people feel that way after they've been admitted. They're finished, but they're not finished. This is a long thing. They need frequent labs, okay? All right, what's next? Okay, adrenal glands. So we move from one gland to the next. So here's your picture of the adrenal glands. Bring you back to your anatomy. Here they are. They sit up. They're little triangular shaped deals. Also very, very vascular. Now, this is off of your aorta. You see all these little vessels here, and there's more of them. And there's all the collateral circulation from your splenic circulation and your mesentery and all. Very vascular. They sit on each kidney, and they have, you'll remember there's a cortex that's this inner layer of it, and then there's the, this outer layer, and there's the medulla, the brains of the operation on the inside. Okay, so in the medulla, you have your sympathetic neurons. These sympathetic neurons secrete catecholamines. And catecholamines, you're probably thinking, oh, neurotransmitter. Well, they act as hormones when they come out of the adrenal gland. And this is your epinephrine, your norepinephrine. Who's trying to come to class? Hold on one second. Your norepinephrine and your dopamine. And they bind to adrenergic receptors. And then they're going to affect all the body systems. So it's important that, you know, we're going to refer to these epi and norepi and dopamine time and time again. Okay. All right. So in the cortex, what are our three main steroid hormones? This is not news to you, obviously. So we have glucocorticoids. That's main one is your cortisol, and it's going to regulate metabolism. It helps you as a glucocorticoid. It's going to help you increase your blood sugar when you need it. It's your physiologic stress response hormone. It inhibits inflammation. Cortisol plays a big role in driving functions in the body. You have mineral corticoids like aldosterone. We talk a lot about aldosterone in this class, you probably noticed. So it's the regulation of your sodium and your potassium. It holds on to sodium and water. It releases potassium and hydrogen. That's what aldosterone does for a living. Then you have androgens, and it's part of growth and development of men and women, but it's the sexual activity in women also that it plays a part in. So a lot can go wrong when you have adrenals, not just with regulation of metabolism, but also with support for other organs and like in this case, you know, ovaries and whatnot, and your fluid balance for sure. Okay, so let's look at Cushing's. Cushing's, too much. One of the main causes Cushing's syndrome is chronic exposure to corticosteroids. Now think about this, there's several causes. We're looking at iatrogenic again, so it's caused by the treatment, caused by the physician, but it's not an intentional thing that's being done to somebody. Take your COPD patient. You know, I know they try and get a lot of exposure with that when you're in the 101 class because they're good patients to learn from, do assessments on and whatnot. So somebody who's had long-standing lung disease and has been on corticosteroids a long time, that's going to cause a problem here because the administration of corticosteroids, we try and meter it. We don't just give you a high dose and tell you to stay on it the rest of your life because we can suppress your own drive. But people who need steroids need them. So how do we, if you have a upper respiratory something and you go to your doctor or you go to a doc in the box, some urgent care somewhere, and they say, oh yeah, here, I'll give you a quick burst of steroids. And they might give you 3 days, 60, 40, 20, you're done, or 40, 20, 10, you're done, whatever. Someone who's on a longer term than that has to wean very, very, very slowly. But somebody who has COPD likely is on this a lot. And so they stay on it and they have high doses. Your body has it, and then we're giving you some besides. So there's even people who are transplant patients. It was the original anti-rejection drug is to put them on steroids. And some of them, they've been on it and that's what works for them. So the doctors don't want to change it. But you have to think of the impact it has on the rest of the body being on steroids like that. So aside from iatrogenic, what else can do it? Adrenocorticotropic pituitary tumors. So this is Cushing's disease. This is a tumor now that's up in your brain. It's a pituitary tumor, but your TH release is up there. And so now you have this tumor that's taking the secretion outside the feedback loop, and it's just over-secreting because where your tumor is where the ACTH releases, and now you have lots and lots of cortisol. Adrenal tumors can do it. Now, this isn't up in your pituitary, this is now in your adrenal gland. But now you're growing a tumor that's secreting cortisol from there. You remember, ACTH in your pituitary is what stimulates cortisol release from your adrenal. So now we're in the adrenal gland and you have a tumor and it's secreting. This is typical more often in women than men, and it's typically childbearing-ish ages. Ectopic release. You can have ectopic ACTH production. This tends to be seen more in men, and this is from lung, pancreas, sometimes colon cancer. And so the cancers are other places, but the cells are diseased and they're autonomously secreting ACTH. So that's a problem too. Okay, so what do you see? Well, what are the effects of corticosteroids? Think about it. Weight gain, right? They have unusual deposits of fat. The trunk, the face gets big and round. The cervical spine, just on the top of the spine, that's where they get a fat pad. It's just cortisol alters your fat distribution. And that's what it does in somebody with long-term high levels of cortisol. Protein wasting, muscle wasting, it's the catabolic effect that you get with steroids long-term. Hyperglycemia, this is a glucocorticoid. So if we're giving you increased amounts of it, it raises your blood sugar. You probably learned that back in 101, that you have a patient who's on steroids, you gotta be checking her blood sugar, right? Osteoporosis, long-term use of steroids decreases your bone matrix from the inside of your bone. You also lose collagen. You also have delayed wound healing because of that. Can take somebody longer to heal. So when you think that someone's on steroids, if you have an inflammatory reaction, you have a rash, you had in the garden, you get poison ivy, and it's just bad. It's inflamed. It's more than just run-of-the-mill poison ivy. I mean, it's really bad. They're going to give you steroids. Steroids are going to decrease cell renewal. That's how they decrease inflammation. So it makes sense then when you have a patient who's been on long-term steroids, they have delayed wound healing. You can't have a decreased inflammation and an enhanced wound healing when the effect of the drug is decreasing cell renewal. So the other thing is mood disturbances. This comes back to roid rage, somebody who, that's probably a wild example, but somebody who's abusing steroids to bulk up or whatever, they tend to get, you see it more clearly in them, the fluxes in their emotional status. So, but the average person who's under controlled, 40 milligrams a day or something, over time will have mood disturbance as well. And again, it's not them that pick up on it, it's people that live with them. Okay, so what else do you see? Mineral corticoids, don't forget, if this is the adrenal we're talking about, it's more than just the cortisol. So mineral corticoids, hypertension from the fluid retention. So if you have an excess and you're stimulating the adrenal, it's going to stimulate aldosterone too. So what do we talk about aldosterone? It's holding on to your sodium, holding on to water. It's going to make people hypertensive, and it's going to deplete your potassium and your hydrogen ions. So they also get severe acne. If you see somebody who's cushingoid and or been on treatment for a long time, you see their cheeks break out. And it's really due to the fact that it's stimulating androgens as well, and that's going to increase the sebaceous cysts in your, the sebaceous glands in your face, and so they get cystic acne. What else? So the typical presentation you see is that centripetal obesity. The arms and legs are usually thinner. The body is rotund. They have this moon face, big fat round face. They have plethora. They have this redness to their cheeks. They're flushed, it looks like. They have purple striae. Sometimes you see it on the abdomen. It seems like stretch marks. Sometimes it's on the legs. You just see purple striae. It's from the, change in collagen and all of that. Women, you see hirsutism. They start getting hair on their face, like significant growth of hair on their face. They'll have menstrual disorders. It's again where those androgens and pre-androgens play into their reproductive functioning. So you see hypertension and you see hypokalemia, okay? So here's your little man, your little person. You can get off a search engine if you like this kind of thing. It's not everyone learns the same way. We try and do a little visual and obviously a lot of auditory. And most of you have a kinesthetic piece. You're all writing. Okay, so diagnostics, what do we look at? Well, history and physical, they go by. They see this person who presents rather centripetally, and they're going to start asking questions. If you look like a cushingoid patient, if you have this round face, and you have these other things in your history, they're going to figure out what your main issue is. So we'll go by the history and physical. Then they can measure cortisol levels. We can easily draw a cortisol level. But just having it doesn't tell us the whole story. So typically what they do in the hospital is they order what's called a low-dose dexamethasone suppression test. Now, I've worked in a lot of hospitals over the years, and some of them have a little bit different protocol. You have to know the one where you are. But basically, the theory behind it is, let's go and give you a dose of glucocorticoid when we know your diurnal rhythm should be low. So your diurnal rhythm, twice a day, you have a peak and you have a trough, so to speak. So you have in the morning your cortisol, maybe 5 o'clock or so in the morning, your cortisol starts revving up. It's going to help you get through the day, get your body metabolisms going, get all your function going, get everything set. Then you have another release in the evening, but it's less. And it's really going to help you repair and restore overnight while you're sleeping. This is why people who work nights, and I work nights for years, I know, you have an adaptation in the beginning because your diurnal rhythm is upside down. And you can work with it, you can get around it, but that's why people sometimes have difficulty. So what they do here is at night, we used to have to give it 11 o'clock, let's say. They're going to give you 1 milligram of a glucocorticoid. So they give you dexamethasone. Now, what that should be doing is if you're normal, if the body registers that glucocorticoid in the body, it will suppress your own cortisol release in the morning because you have more cortisone on board. So they'll draw your levels in the morning and they should be down. If not, then you have a tumor or something somewhere that's secreting it. Because why would you raise a cortisol level even higher if there's enough cortisol in the body? So you can get false positives. Phenytoin is not a good drug to be on to do this test. It's going to skew it. Rifampin, which is rifampicin, that's another one. Oftentimes meds for depression also, a lot of the psych meds. So doctors know this. Obviously, they go down your meds and figure this out before they're going to run a test like this. But it's something you need to keep in mind because it can give us the wrong result. All right, what else can they do? We can do 24-hour urines for elevated levels. Now, we're looking for 17 ketosteroids is what it's called. It measures metabolites of androgens, among other things. You know how 24-hour urines go. 24-hour urines mean you're collecting urine for 24 hours, the patient's urine. So what happens? You get the first morning void and you dump it. We don't count it because it's been all night. You put a sign up in the bathroom, a sign over the patient's bed, a sign on the door. You tell everyone, you tell your text, you tell everybody, you put a hat in the toilet, put a hat the other way so that, you know, you can't miss the hat in the toilet when they go. You put a sign anywhere you can think, on the mirrors, you tell your families that come in. Everyone has to capture the urine for you. It's not a 24-hour. If you're like, well, I got them all but 3. We don't know if something's peaking or troughing in that time. So usually the doctor will say, then start over again tomorrow, and you have to do it again the next morning. It's attention to detail. So be very careful with your 24-hour urines. It does matter. You know, we could have missed 2 or 3 voids that, you know, it could have meant the difference in levels and changed the therapy completely. Typically, if the patient is incontinent, the doctor will have a Foley put in just for the 24-hour collection. Now, we hate to put Foleys in if we don't have to because of all the CAUTIs and but we have to, if we're really trying to capture a 24-hour urine, they want it accurate. So they would do that for the 24-hour collection and then not if they don't think the patient needs it. We can also do just late night plasma and salivary cortisol testing. You have it in the plasma, you have cortisol in your saliva, and at night it should be less. That's when the body needs it least. So if we check it at night, we can see if it's high, it shouldn't be, and if it is, we know there's an ectopic source somewhere. They're going to watch the CBCs and DIF, see if anything else is skewing anything, check your blood chemistries. They're always watching your sodium, your potassium, your glucose, because we're dealing with the adrenal here. And if they need to go find a tumor, they're going to scan you. So, all right, so into professional care. Well, obviously we want to normalize. That's the goal with all of these, right? Let's normalize the hormone. If it's a pituitary tumor, they're going to do that transsphenoidal surgery we talked about yesterday. If it's an adrenal problem, they can go 2 ways. They can do a laparoscopic removal, but if they think it's malignant, they have to open you and do an open one, which is a significant surgery. The kidneys are retroperitoneal. They have to go in and go down for them. Now, the thing is, the laparoscopic one is so much easier, and it's easier for the patient, and it's less risk and all of that. But if it's cancerous, as they're taking it out, they're seeding that cancer all the way out. So if there's any question from the scanning and all that this is malignant, and you can certainly have malignancies in the adrenal gland. I don't know if you've had patients with them, but breast cancers, lung cancers, colon cancers, a lot of things metabolize to the adrenal glands. And you can imagine the havoc it causes with the catecholamines. So, you know, if they think at all that it's malignant, they're going to have to open you. They can do radiation for people that are non-surgical candidates. And then we can do medicine as well if we have to. All right, so here it is. If you're a poor candidate for surgery, then we're going to do what's called a medical adrenalectomy. So this is a suppression of cortisol with medication. Not a nice thing. I mean, you don't really want to be screwing up with someone's cortisol if you don't have to. But if you're in this cancer situation where you're releasing it and it's throwing the rest of your body out of whack, they have to treat it. And if we can't just go in and remove the tumor, we'll have to do this. So what do they give you? Well, Nizoral, you've probably heard about it. There's commercials about it. You see it in print ads, whatever. It's ketoconazole. It's an antifungal. So people might use it for fungal infections of their feet or something. You know, it's topical. We put it topical. We tend not to give ketoconazole, aminoglutathione, mitotane. We tend not to give them by mouth. Ketoconazole, if you have a really bad athlete's foot, they're going to say, well, keep doing this or keep doing that. Try not to give you anything PO, because taking it PO, we know what it does is it interrupts, it suppresses your cortisol synthesis. That's a dangerous side effect of a drug. So the FDA is not too thrilled with that. Now, if you have this condition that we have to treat this tumor and you're not a surgical candidate, then they say, you know what, that ketoconazole that's normally used for fungus, let's take that and give it to you PO, and it's going to suppress your cortisol synthesis, and we can control this tumor that way. So it's not that you have a fungal infection, it's that you have this tumor and you're not a candidate for surgery at the moment. Needless to say, you won't see this often, but when you do, that's the deal. So Cytodrin is your aminoglutathamide, and Lysodrin, the same thing. They all interfere with cortisol synthesis. So that's a dangerous thing unless you have this kind of situation. All right, if it's iatrogenic, if it's because you have been on long-term steroids. I mean, we had a patient, I want to say about a year ago. The student said to me, 2 years on 80 of prednisone a day. That's a long time to be on 80 of prednisone. They can try a gradual discontinuation. So they would go, you know, who knows, 80 for how many days? Then they go 40, then they reduce the dose. They also reduce the days. So they would get to a point where they say, okay, you're coming off of 80. Maybe you do 80 on Monday, 80 on Wednesday, 80 on Friday. And then you go to 40 every day, and then you go to 40 every other day. I mean, it takes a long time to wean somebody off who's been a long time on that. So they do what they can to get you off of it. And nobody should be on it that long unless you're transplant or something that requires you to take it daily. And then we wouldn't be weaning you off of it. So this is not done if it's for replacement. So remember we talked about somebody who has destruction of the pituitary, and we have to replace the essential hormones. We have to replace that ACTH because the pituitary is removed or it's damaged, whatever the story is. So if that's the case while you're taking these long-term steroids, then there's no gradual discontinuation. You're living with this iatrogenic condition because it's the only way you can live. We don't want to suppress your hormone level at that point. Okay, so here's your treatment of Cushing's. If it's pituitary, we are back up to doing the transphenyl and getting your tumor out. If it's adrenal, hopefully they think it's benign and they can go in and do laparoscopic removal. It's just better for the patient for sure. If not, they'll do an open adrenalectomy. Okay, so what do? You're the nurse. What are you going to do for this patient? Well, assess them. You know now about the adrenal gland. You know how the levels get screwed up and the problems this can create for the person. Keep your eye on them. Somebody with Cushing's syndrome, sick. Here they are, and you're in your care for the day. You got to pay attention. Watch the vital signs. Watch the daily weights. Daily weights tell us a lot. Hit the button on the bed. Can't you tell this is a thing for me? It drives me nuts when somebody will go, I heard a doctor one time in a unit saying, 6 days, nobody can get a weight on this patient. And they were like, oh my God, he's so angry. I don't blame him. 6 days, not one nurse could get a weight. So it's crazy. Anyway, so what else? We're going to check the labs. We're monitoring electrolytes all the time. The patient's risk for infection is significant. Cortisol plays a part in your immune system. If something's skewed at all, that's a problem. The other thing is inflammation. I've talked about this before. When you're on anything that is immunosuppressive, an immunosuppressive drug, steroids for a long time, anything like that, it decreases signs of inflammation. That's why they're giving it to you. The person who had the poison ivy I was talking about, that it's just crazy, swollen and awful, they're giving you steroids for that. What happens? All that swelling and redness goes down. So you can't pick up signs of infection or signs of inflammation elsewhere in the body if you know they're on this kind of suppressive med. So is their phlebitis going to be glaring like a phlebitis? No, probably not so much. So when you're assessing that IV site, you're feeling, is it hard? Is it indurated? Is the vein free to flow? Do I get a good flashback? What, you got to assess carefully these things. I think I told you, I don't think I was doing a Zoom review. I think it was in class. I told you about that transplant patient we had. And she was on all those immunosuppressive drugs. And she had a kidney done. And she came into the ED, and you go into rejection of an organ, it's usually nausea, vomiting, diarrhea. Same it is for everything, right? It seems everything we study is nausea, vomiting, diarrhea. But so the transplant team always tell them, if you're home and you have nausea, vomiting, diarrhea, go to the ED. So she comes, she feels miserable. And they check her kidney levels and they're fine. And there's no, you're good, they send her home. Viral thing, whatever, 24 hours, whatever, take your fluids, get some sleep, it'll pass. She comes back again, she's miserable. Well, it's not your kidney. Transplant comes running again, checks her out. It's not your kidney, and they go running away. And what does she do now? Gave her a bag of fluids, blah, blah, send her home. She comes back a third time, and she's like, I am sick, and I'm not leaving. So where do they start now? So they start doing other tests. They scanned her abdomen. She had a ruptured appendix. A ruptured appendix. She had no rigidity. She had no inflammation. She had no anything other than she was miserable, vomiting and nausea, miserable. So, and now what? Peritonitis, mortality, morbidity is so high with peritonitis. She's got a ruptured appendix. She's been eating. It's not like she was cleaned out for this. So she's been eating, her bowel is full of stool, and now it's ruptured, it's in the peritoneal cavity. So she had none of those signs at all. So be careful when has high cortisone levels. Cardiac symptoms you're going to watch. What else? Diabetes, it's going to raise their blood sugar. You got to, even if it's not that they are diagnosed diabetic, the fact they're on this drug is causing them to have high glucose. If it's iatrogenic, if it's the tumor, the fact that it's over-secreting ACTH is going to raise their glucose level, and you have to treat it as if it's diabetes. We know the damage that happens with high blood sugar, the damage it does to the body. So you got to watch for that. Emotional status, that just comes with, having high cortisol levels and all that, and the person won't know. And you might not know either because you never saw them until 20 minutes ago when they came under your care. But your family might be telling you there's been a change. Okay, so if they're surgical, you have all the pre and post-op care. Watch for DVTs, watch for pulmonary emboli, watch for pneumonia, all those things. And the adrenals are very, very vascular. And there's a risk for hemorrhage, but with a hypertensive situation, the risk for hemorrhage is greater. So carefully assess your patient.
Okay.
Yeah.
For the blood sugar levels, would they potentially get like a type 2 diabetic medication to help with that?
More likely insulin while they're in the hospital because they want a quicker response. And the danger is if you stay with what happens, what's the whole premise behind the damage done with high glucose? Think about it. Your glucose molecules are big and sticky. And what happens is they get down to your very tiny, minute circulation and they get stuck and they impair that vascular flow. So think of your diabetic patient who, your type 1, who, what happens? They lose sensitivity in their feet first, right? Don't they eventually, because of vascular disease, lose a toe, half a foot, BKA, whatever? Where else is there tiny vasculature? In the eyes, don't they get retinopathy? Where else? It's in the kidney, in the glomeruli. Don't they lose kidney function? So think of the damage we know that sustaining a high glucose does to the body. And then knowing this person already has this issue and now they have these high glucose, they're just going to address the high glucose for what it is. So if they're in the hospital and their sugar's high, they're going to say, let's give them a little regular with this, let's get them a little coverage with that, and they're going to cover it that way. And the patients don't like it. They'll say, I'm not diabetic. I don't know why you give me insulin. And it panics them. And you have to just say, this is for now. It's because of your adrenal situation, this tumor you have. Once we can get a hold of this situation, I'm sure we'll see your blood sugars fall. Yeah. Yep. Okay, so what else do you do? Watch the I&O, keep your lines patent. You don't ever want to have a patient that you don't have a patent line. And we learned, even on the transplant floor, my students learned how many times the adapted IV was the last thing to go. And on that floor, they took it out in the lobby because how many times they would take it out, take the patient down, and they code in the lobby. I mean, and they shouldn't have. I mean, shouldn't have. We hope nobody does, but they are post-op. They had a big surgery, they had a transplant surgery, they throw an emboli or something, who knows? But we would have pulled the IV, and now everyone's rushing to the lobby, and we have no IV access, and we have somebody with no BP. So it became pretty much a pattern that they would say, take the gauze and the tape with you, and when they're getting in the car, you pull a line in case we need it to the end. So, I mean, it was crazy. So keep the lines patent. It doesn't do any good to have a deadline. Remember, there's delayed healing. If the corticosteroids drop too quickly, your patient's going to be adrenally insufficient. So 24 to 48 hours post-op is critical. We watch them like a hawk because they'll give them steroid support in the OR. Let's say they have to take both adrenals out, one adrenal out. They'll give them that steroid support to replace it for that tumor. They'll say, well, let's give her another dose of this, another dose of that. They'll do that. But then now you're out on the floor recovering and your body still has a need for cortisol. Is your one adrenal that didn't have the tumor still good enough to meet that need? Maybe. But how do we know? We got to assess the patient. You got to watch the blood work, watch what's happening to figure out what's happening with this patient if it's enough. If it's not, and you drop too quickly, you're going to have all the signs of adrenal insufficiency, which we're about to get into. But if nobody orders them, supplemental sources or things like that, it's iatrogenic again. We knew you had an adrenal removed. Who's not watching? We have to watch to support the body. So they're typically on bed rest until their blood pressure is stable, until the hyperglycemia is under control, and everything starts to look better. But this patient bears watching, really. Okay, so your nursing diagnosis: risk of infection. They have lowered resistance. They have suppression of an immune system. Overweight related to increased appetite, caloric intake. Some people are overweight, some people are not. Some people, if they're on high doses of steroids, are just driven to eat. They feel the munchies all the time. Some people not as much. It all depends on what their underlying stuff is and if that affects their appetite. Their self-esteem is a big thing. They look in the mirror and they see that big round moon face and it bothers them. The redness to it bothers them. Impaired skin integrity, they're not going to heal well. They have skin fragility. So that's another one that's very pertinent. Okay, so it's 10 till. Take your break till top of the hour, and then I'll see you back, okay? Okay, I'm going to start back. We talked about these nursing diagnoses. So next we're doing adrenal cortical insufficiency. So this is the opposite, okay? This is hypofunction of the cortex. The primary cause is Addison's disease, and it affects all the adrenal corticoids. It's the glucocorticoids, mineralocorticoids, and the androgens. A secondary cause is lack of ACTH secretion in the pituitary that we've talked about. And that's mostly your corticosteroids and androgens. It could be pituitary disease. It could be you've been on long-term medication that has suppressed now your connection between your hypothalamus and your pituitary, and it's just not releasing like it should. You've been on therapy for a long time. So we'll look at some things here. So Addison's disease, in the United States, we're talking 80% of Addison's is autoimmune. I talked yesterday about how the autoimmunity in this country is significant. So adrenal tissue is now destroyed by antibodies the body is building up against it. That's how the autoimmune thing works. So the cortex is destroyed and you have the loss of the gluco and the mineralocorticoids and your androgens. Other causes can do it. Amyloidosis. So what is amyloid? Amyloid is this abnormal protein. These are fibrils, and it should be in your bone. And for some reason, in some people, it comes out and deposits in your tissues. That's thought to be autoimmune. It can be fungal infections. It could be AIDS patients, you know, they're treated for fungus all the time because they're a prime petri dish for it. The poor things have no immune system to speak of by the time they're in AIDS. Everything is opportunistic. So we may have to give them a lot of antifungal treatment, which we learned we do to suppress cortisol when you have too much of it. And so you can be treated with that it now renders you to be have Addison's and be insufficient. Cancer certainly can do it. Cancer therapies can do it. So iatrogenic causes are adrenal hemorrhaging. Anybody who's on anticoagulants, you know the risk is we are anticoaguling the blood. So we're hoping that they're not going to clot, right? For whatever reason. We don't want them to, you know, whatever their situation is, we think they're going to be prone to clotting. We're trying to avoid that. In doing that, you can bleed anywhere. You had a question on one of your tests about somebody who's on heparin therapy, and a low BP was something you had to notice because it would be indicative of someone bleeding someplace. It's not always obvious. It's not always they're vomiting blood in your face, or you take them into the bathroom and their stool is all blood. It can be insidious in the body somewhere. One of the places you can bleed from anticoagulant therapy is in your adrenal glands. It's very, very vascular. So it can happen there. Chemo can always do it. The ketoconazole I talked about. Even bilateral adrenalectomies. If we have to go in because you have disease and it's in both adrenals and they take both out, you are automatically adrenally insufficient. And we have to treat you for that or you won't survive. You won't survive. Okay, so what do you see? Well, unfortunately, this disease is well advanced before it's diagnosed. It's like cirrhosis in that case, or it's like renal disease. Usually renal disease, you have 20% kidney function before they find you're diseased. This one is about 90% of your cortex, they estimate, is destroyed before you're symptomatic. So vague symptoms, muscle weakness, fatigue, lack of appetite is not going to make you run to your doctor and say, you might say, I don't feel great, but you're not going to run. And the first thing isn't going to be, oh, I bet she's adrenally insufficient. So insidious, right? Now, hypotension is going to make them look twice. A low sodium, now the plot's getting thicker. An increased K, because now we don't have aldosterone. If you have an insufficient adrenal gland, you're not supplying enough aldosterone. So you don't have sodium. It's not retaining water. So you are hypotensive. You're retaining your K instead of getting rid of it. So now you're hyperkalemic. You'll have all that insidious nausea, vomiting, just feeling yucky kind of stuff. But the other things are more what's going to, help us zoom in on what's wrong with you. Also, someone gets hyperpigmentation. This is a bronze color. This is not tan. This is not jaundice. This is a goldy bronze color. It's very, very distinctive. And what happens is when you have adrenal insufficiency, your melanocyte secreting hormone, your B lipitrins trip that melanocyte secreting hormone to put this color in your skin. So it's not seen in a secondary disease. It's only seen in primary, and it's a key factor. One of my neighbors came out to me, and another neighbor saw us both talking, and she came over and said to her, if you've been away, you're so tan. And the whole time I'm thinking, this isn't tan. This is bronze. She's got adrenal issues. So,
Dr. Benetti,
yes.
how would you find that manifestation in someone of darker skin?
That's a great question. And I can tell you, I've had people with different skin tones who have it. It's still a goldy, glazy, bronze color on them. It's a very unusual tone. And so even someone of a dark complexion, you're going to look and say, this is not their complexion. What is this? That's a great question, but it becomes obvious to you because it's the glow tint, and it's not a yellow that they get with long-term renal disease, and it's not a jaundice. It's a different, once you see it, you know. One time I filled in for clinicals with a 101 group, this is years ago, and there was someone coming down the hall who was typically this picture. And they were being discharged or coming down the hall in a wheelchair. And I looked, and they were brand new. They were so cute, my students. And the wheelchair's coming down, and they passed us by and went in the elevator. And when I turned back, they were all like, oh, did you see that one skin? And I pulled them into a pre-conference and I said, what have you heard? And they're like, oh, it's jaundice. I said, no, it's not jaundice. I said, did you see that color? It was like they had the worst bronzer, the gold spray. What did they do? I said, I know. It's a very distinctive thing when you see it. So certainly I encourage people all the time, you hear of someone who has adrenal insufficiency and they've had it a while, go in and see that. You know, I don't say I line tickets at the door and drag people in, but if there's an opportunity like that to even bring something in the room or see them somehow, it's very distinctive. Yeah, good question though, Melissa. Okay, so here's your little picture. It's kind of not the best bronzy skin in the world, but it gives you an idea to connect that color with that. All right, so what are the complications of having adrenal insufficiency? Well, the big one is Addisonian crisis, and this is not good. This is an acute adrenal insufficiency. It's life-threatening. We've talked about how you cannot live without cortisol and your functioning adrenal glands. You cannot. Again, pretty relatively small glands with a huge job. So what are the triggers? Stress. Not, again, too stress or stress, I'm going to get the job or get into college or something. We're talking huge surgery, multiple trauma, a burn, physiologic stress. Sudden withdrawal of steroids, which is why the importance of teaching people on maintenance. If they've had a pituitary damage and they have to take steroids their whole life, they've got to take them. If it's someone who doesn't want to be on steroids because of a transplant and it's one of their adjuvant drugs, they have to stay on it. If it's somebody who's an asthmatic or COPD and they're given this and they hate going on them because their face gets round, they have to stay on it and taper. Someone like that could taper, the others cannot. But sudden withdrawal of steroids is never good. A post-op adrenalectomy. People forget this one on the floor. If you know the patient you're taking care of had bilateral adrenalectomies, you got to watch them for adrenal insufficiency and Addisonian crisis. The other thing that does it is sudden pituitary destruction. I talked about this. Think of my poor patients who have been assault victims, who've been beaten, who've been shot in the head, who have shot themselves in the head. It's sudden pituitary destruction. They're having a massive trauma, a massive injury now, and what can the adrenals do to help them? Nothing. So on top of this, on top of this horrible trauma and trying to get these people stabilized, it's on everyone's frame of mind that there might not be a pituitary. And without it, this patient's going to be in the Addisonian crisis on top of everything else they have. And sometimes they don't make it because of that. Okay, so what are the symptoms? Low BP, tachycardia is compensatory. Hyponatremia, you don't have aldosterone, so there's no holding on to sodium. You have potassium because there's no dumping it. You're hypoglycemic, so you don't have those sugar reserves to help you because you don't have cortisol, you don't have glucocorticoids. They have fever. This speaks to that immune part of the system. It supports your immune system, and now it's out of whack. They have weakness, they're confused. The hypotension can lead them to shock state. It does not respond to the usual thing. If you go into someone's room and they're having an episode, maybe if you've been in the hospital and clinical or you work as a tech or something, someone has an episode where they look like they're passing out or they're not doing well or whatever, and they call a rapid response. What's the first thing everybody does? Open the IVs wide open. You can open the IVs on these people. Is it going to help them? No, no. The issue you have to know as the nurse is you got to be telling somebody, wait, this patient had bilateral adrenalectomies. What they need is steroids. That's what they need. It's not that we won't support that then and have IVs running, but it's not going to pull them out of a syncopal episode or a hypotensive episode because that's not what's driving this problem. So that's an important point. Now, what do we do for diagnostics? All right, somebody's adrenal insufficient. They're not in Addisonian crisis yet, please God, but they're in adrenal insufficiency. So what are we going to do? Well, we can do an ACTH stimulation test. By now, you know, there's a test for everything in adrenal land, in endocrine land. So here's an ACTH stimulation test. And they get a baseline cortisol, and baseline ACTH level, because we can draw that. And then the patient's given a dose of cosentropin. That is artificial ACTH. And then we draw your levels in 30 minutes. So a patient with Addison's will not respond because Addison's is primary, right? So primary AI, you'll just have higher ACTH levels. You still won't have a response from the adrenal gland. Let me say that all again. So we're going to get baseline cortisol and ACTH, right? Then they're going to give them a dose of cosentropin. That's our manufactured ACTH. And then they'll draw the levels again in 30 to 60 minutes. Addison's disease is primary adrenal insufficiency. So somebody with Addison's will not respond because it's the gland that can't do it. The gland can't respond. Your pituitary was probably giving you ACTH and the gland couldn't respond to it. You're going to have higher ACTH levels. When we redraw your ACTH levels, those will be higher because you had the level that your pituitary gave you, and then I gave you one in your arm. So the ACTH levels will be sky high. The cortisol levels will be nothing because your adrenal gland cannot respond. Okay, so diagnostics. If you have an abnormal ACTH, like that's not enough, you know, that test didn't go well, they can follow it up with CRH. Now, you know there's a cosentropin releasing hormone up in your hypothalamus that's going to trip your ACTH in your pituitary. We don't spend a lot of time on hypothalamic connections here because you had it in anatomy. But, so what are they going to do here? They can give you CRH. So again, they're going to say, well, then let's give CRH. Let's to be sure, let's give CRH. And then let's draw ACTH levels and cortisol levels and see what happens. With Addison's, you're still going to have high ACTH because giving you more CRH is going to make your pituitary give us more ACTH. But you're not going to have cortisol because Addison's is primary and your adrenal gland still won't respond. With secondary adrenal insufficiency, you're not going to produce ACTH. If I give you, if they're trying to clarify if it's secondary, then we're looking to the pituitary to be the one that's at fault. So if I give you CRH, like your hypothalamus does, what's going to happen? You're still not going to produce ACTH for me. Whether your hypothalamus gives it or whether I give it to you in your arm, you're still not going to produce it because your pituitary is the problem with secondary. Okay? You got to think about it a minute, but it makes sense. Okay, more diagnostics. What do we look at? Well, we're going to look at everything we have on you. Are you hyperkalemic? Yes, your electrolytes are going to show you're hyperkalemic. You're going to be hypochloremic. Sodium and chloride go together, and your sodium is low, right? We have nothing retaining your sodium. We have nothing retaining water. We have no cortisol, so you're hypoglycemic. You don't have high blood sugar. You have anemia. You know, you're just not, you're not coming along with all your functions. You have an increased BUN. Well, where does your BUN come in with all of this? You know, you're in a dehydrated state. And so that's where you have an elevated BUN is caused by many, 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 many things in the body, which is why when we measure kidney function, we always measure creatinine. Creatinine is a more reliable indicator of kidney function. We'll measure BUN along with it, but we're looking to the creatinine. So BUN, this is another one of those cases where BUN is elevated. Burns elevated, MIs will elevate, I mean, anything. So the EKG from the hyperkalemia, you're going to see your peak T waves you learned about. A CAT scan can help us say, is this tuberculosis? Because other places in the world, TB is what causes this. It's not a problem here in this country to that degree. Is it calcification? Are the vessels just bad? Is it a fungal thing? Is it an autoimmune disease? CT will help differentiate that because if there's a tumor or something, or failure or damage or something, CT is going to show that. All right, so interprofessional care. Well, it's based on the underlying cause. So we can give replacement therapy for sure. Hydrocortisone has both glucocorticoid and mineralocorticoids. So hydrocortisone is the drug of choice. So like Solu-Cortef, right? Now, glucocorticoids have to be increased for this person if they have to live in this state, has to be increased for stressful events in their life. So what's a stressful event? Again, I'm not saying 202 isn't stressful, your job isn't stressful, but we're talking about maybe death, divorce, physiologic stress, a procedure, colonoscopy or something. You have to have some adjustment done because your body can't accommodate. And when your body's going under anesthesia and coming up, or going under sedation and coming up, or you're having a bone reset, or you're having a, tooth abscess worked on or something. So we have to increase your glucocorticoids for that. That's a lot of patient education. Mineral corticoids are replaced daily. Typically, it's Florinef is what they use. It's fludrocortisone. And androgens can be replaced if it's, for women especially, they'll give them DHEA, which you probably had very little experience with. It's not used very frequently. It's your dihydroepiandrosterone, and it's really helping support the androgens that feed estrogen, and that helps women. They'll add sodium chloride to the diet because you're not retaining sodium, but you have to watch their BP. You have to watch it. Because now when you add sodium chloride, how much fluid retention is that causing? So you can't go too much the other way. During a crisis, they're going to give them normal saline or D5 for hypotension, but don't forget, they need steroids. Fluid alone is not going to do it.
Jane,
Yes.
when you're saying that we're going to give increased glucocorticoids during stressful situation, are we doing that? Like if they experience a stressful situation, we're administering that to them?
Yes. So let's say they're in the hospital and we know that they have this issue and they have to go have a procedure done, or they have to go have a surgery, or something's happening to them in the hospital, they need a coverage dose for that. We're also teaching them, so when they go home and they're living with this, that if there's, a death or, something super stressful in their life, something they have a lot of anxiety about or whatever, the body can't cope. So they have to call the doctor and say, I'm anticipating having, my bunion done, or I'm anticipating having a root canal or tooth implants or something like that. And the doctor will give them doses to cover themselves for that on top of what they take daily. Yeah. Yeah.
Thank you.
You're welcome. Okay, so patient education, big one. So lifelong replacement in divided doses. So the glucocorticoids, typically you get 2/3, you get more in the start of the day because your body would have provided you a greater dose in the morning to get you going for the day. We do 1/3 probably in the evening because you need it again to get you through the night so your body can recoup and replenish, but you don't need the dose you need for daytime. Mineral corticoids once a day in the morning typically is enough. The with Florinef, they'll tell you to increase your sodium intake and watch your BP. So we tell people you got to get a sphygmomanometer. The automatic ones now are really good. They're all time tested, and you get them in a CVS or something. They're not that expensive, and they have to learn to take it and be compliant with it. So no excess physical activity. So what does that mean? On a person who needs to be healthy, we're all out walking, getting our steps. So they want to go walk 2 miles, that's probably okay. You want to do a triathlon like you always did, not so much. You can't do a marathon. You can't do a triathlon. That's too much physical exertion, even if you've been good at it your whole life. Not anymore. So that's a big thing. And we've talked about these procedures, Crohn's disease or something, or outpatient procedure or something like that. You need to get support, all right? Okay, they should have a medical alert bracelet on, and people don't like to wear them. They have to pick their poison, a necklace, a bracelet, something, because someone coming to their aid on the street, EMS, something not knowing, is gonna think fluids will do the trick, or if not, it's a heart attack or something. This is not gonna do the trick, just fluids. And they should carry hydrocortisone with them, 100 milligrams. They all have rescue drugs. Okay, so corticosteroid therapy. Well, suppressing inflammation we know can be therapeutic, but you have to realize they're suppressed. So you're not going to see the redness, the fever, the swelling. I know I've talked about it. It's an important point. Okay, Underlying diseases can be reactivated when someone is immunosuppressed, even if it's steroids, dose dependent. So you might have had TB in the past, it could raise its head. Hepatitis, viral hepatitis could raise its head. You know, you have to be careful. You take steroids with food. It decreases cell renewal, so it causes gut rot. People will get upset stomach. Teach them no taper if it's replacement. If there's something wrong with their pituitary or their adrenals have been removed, they don't taper. Otherwise, if it's a burst dose for something, you're on this for this, you're on 180 now, we're cutting you down to 100, then you're going to 80, then you're going to 60, how many days you're going. They cannot just go 180 to nothing because they'll cause their own adrenal insufficiency. The risk of osteoporosis is great because you're losing bone matrix. You can't absorb calcium. Okay, so hyperaldosterone. Now we've talked about aldosterone, so you know, I'm going to keep saying retains sodium, retains water, depletes potassium, depletes hydrogen ion. All right, so this is a disorder from excess aldosterone secretion. And here are the words: sodium retention, K and hydrogen excretion causes hypertension, and the person has a hypokalemic alkalosis. Not hard to understand. It's hypokalemic. It's related to the fact that they have sodium retention, they have low potassium, and they're losing their hydrogen ions. So it's a metabolic issue. They're hypokalemic and they're alkalotic because the H is all gone, hydrogen ions. And of course, there's a primary and a secondary. So primary. This is a problem with the adrenal gland, right? It goes right back to the culprit. And is oversecretion of an adenoma. Here's the adenoma again, a tumor up from glandular tissue. Single, multiple sites. Sometimes you have bilateral hyperplasia with this. And it's just a fluky thing that people develop. You know, who knows who's gonna come up with this? So we know it's more female than male. So hormonal influence of women's hormones, maybe. Average age, 30 to 50. It's the cause of secondary hypertension in some people. So sometimes they have hypertension with no other causative agent than to know they've had hyperaldosteronism at one point. Okay, so secondary, this is non-renal in origin. And we're not going to the pituitary, we're gonna look to the kidney. Because where does aldosterone come from if it's not stimulated by the adrenal? It comes from the kidney. Think about the RAS system I've talked about. And I know everyone hates RAS. And you're all thinking you wish you learned it better in anatomy or 101 or whatever. But renin, when you have decreased circulation, perfusion at the juxtaglomerular apparatus in your kidney, whether it's from renal failure, whether you have a renin secreting tumor, whether you have thrombosis, sclerosis in your renal artery, whatever it is, you have decreased blood supply, it's going to secrete renin. Renin plus angiotensinogen becomes angiotensin 1. With angiotensin converting enzyme, it becomes angiotensin 2. Angiotensin 2 is a potent vasoconstrictor that increases aldosterone. It increases sodium retention, increases water, and depletes your potassium and hydrogen. So we're looking here to probably a kidney issue. You could have, you know, just a renin secreting tumor, but it's typically your kidney. All right, so what happens? Well, it causes electrolyte imbalances, increased sodium absorption. So they get hypertension from the increased volume. Sodium grabs the water, it's too much in your vascular space, now you're hypertensive. K depletion from excretion in the distal tubules, it's dumping. With low K, you have cardiac arrhythmia problems, you have muscle weakness, you have a metabolic alkalosis, this is a metabolic issue, and you're dumping your hydrogen ions. You can get tetany from this as well. So hyperaldosterone is a differential diagnosis. If somebody comes in with hypertension who is hypokalemic, who is not on diuretics to be the cause of the hypokalemia, they're going to look to hyperaldosteronism. That's typically what they look at next. Okay, so diagnostics. Well, sodium, We look at aldosterone levels. We can draw aldosterone levels. It's good. I mean, you just draw it. Plasma renin activity. That's a good one. We can do a PRA level. And we draw potassium levels and see where they are. Now, PRA is going to be low if it's primary because the adrenal is the source and it's a tumor that's excreting it. It's going to be high if it's secondary because it's the kidney. And that's where your renin, you release your renin when your blood isn't perfusing well. So it just helps them differentiate a little bit what the levels are. They can do a CAT scan or an MRI. Let's rule out the tumors. That's what they go looking for first. And they can do a plasma. It's called an 18-hydroxycorticosterone test. And they do a blood level in the AM. And if it's really high, it's indicating an adenoma somewhere that's secreting it. It shouldn't be. It's an aldosterone synthesis chain is what they're measuring. And it shouldn't be high in the morning. So if it's up, that's what they're looking at. Adenoma. Okay, interprofessional care. Well, if it's an adenoma, we're going to go get it, right? Laparoscopic, if they think it's benign. If not, they'll open you up and take it that way. Pre-op electrolyte correction. They're going to make sure you're on low sodium everything, case-bearing diuretics if you need them, like spironolactone, eplerenone, those. No grapefruit juice with case bearings, especially that eplerenone does not do well. You might as well give them nothing. Antihypertensives for the extra hypertension they have from the increased circulating volume. That's important for surgery. So, adrenal hyperplasia, we're going to give them the spironolactone we talked about, overgrowth in the kidney, in the adrenal gland. We're going to give them calcium channel blockers because they're having all this arrhythmias probably. They're having this potassium throwing the heart out of whack a little bit. We might need some help with that. Dexamethasone is going to increase inflammation. So it's going to be, what is your patient showing? What does the lab tell us? This is why I say your focus should be on the details you have about your patient, not just that you have the labs back. What are they telling you? It's going to tell you a lot about this patient's condition. Okay, so what do? Assess your patient, the labs, the INO. Watch for cardiac issues. They should be monitored. Check the vital signs before and after surgeries. The BP might not be controlled if only one gland is taken out. If this is an adrenal problem and only one gland is removed, it might not be enough. Some people can't withstand a bilateral in the same surgery. They do one at a time. So don't get duped. Go by, check your patient, do what you know you have to do to make sure they're homeostatic. All right, what else do you do? Well, patients who are on maintenance, spironolactone, amiloride, these case bearings, in men, they tend to get gynecomastia. So you have to educate them that the breasts will probably grow. They're probably impotent. It's the interference with the androgens. Menstrual irregularities in women. Teach them about hyper and hypokalemia because it's important for them to manage. And we're not expecting them to manage it all at home, but if they see signs of shift, then they have to call somebody. So hyperkalemia, you're going to have rhythm changes. They'll notice cardiac irregularities. They'll be twitching muscles. They'll be, what else? Have muscle weakness, just feel a sense of weakness. Hypokalemia, it's muscle cramping. Again, you can have palpitations. Sometimes they're constipated. So it just, just to make them aware of their body systems, they have to know what to look for. We teach them BP monitoring, and they have to be compliant. They have to go back to the doctor and follow up. Okay, so now let's look at disorders of the medulla. The big one is the pheochromocytoma. It's pretty simple and straightforward, but boy, is it impactful to people that have it. This is a very rare tumor. It causes overproduction of catecholamines. You can imagine. Patients get severe hypertension, a pounding headache, rapid heart rate. They're diaphoretic from the catecholamines, they stimulates from the adrenal. and they have abdominal pain, chest pain. They're miserable, miserable, and they've never heard of this. Now, the aggravating factors are many. Who knows what trips it? Number one, you have to have this pheochromocytoma, but what's tripping it? It can be antihypertensives. This is a weird thing, but in some people, you have to have the pheo to begin with, but the beta blocker that they might be on is going to have a paradoxical effect with them. And so the doctor might have put you on this beta blocker for hypertension or whatever, and that's not the effect you're getting from it at all. And you're back to the doctor pretty quick. They're going to look into it more to say this isn't essential hypertension like most people get. This is something else. And it'll put them on the trail of a pheo. Now, could be opioids because they mess with your kappa and mu receptors. Could be contrast material. All the iodine in it has this effect sometimes, especially if you have a pheo in your adrenal gland that you didn't know you had. And tricyclics. You see how tricyclics don't do well with a lot of conditions and a lot of medications. So it's usually young to middle-aged adults. So you can imagine the terror. They're otherwise young, healthy people who never heard of this thing. And all of a sudden, they're sick with this. It's terrifying. So I've seen them in the ED. They're racing back and forth. They have this horrible headache. Their heart is pounding. They're drenching in sweat. They're tremorous. And it's not just, this is not a panic attack. It's not. And it lasts minutes or it lasts hours. Thank God they're young. It would kill an older person, really. I mean, it's horrible episodes, horrible. So what do? Well, if they suspect you have a pheo, they're going to do a 24-hour urine for fractionated metanephrines. These are catecholamine metabolites that we can measure. And it checks for catecholamines. We check the creatinine to make sure the kidney's okay. But your metanephrine levels are elevated in 95% of the people. You only get a serum level in episodic attacks. So if I'm measuring your serum for epinephrine, norepinephrine, dopamine, or whatever, it might, if you're not in an attack, it's not going to be high. If you're in an attack, try and get you to sit still for me to draw that blood and try and capture those catecholamines. I mean, these poor people, you have to see them. It's awful, awful. And if it's just a few minutes long, they're coming up to you saying, don't let that happen to me again. I can't do it. I can't handle it. And they know it's coming. They're afraid it's starting. It's awful, awful. They're pretty dramatic when you see them. So the treatment is to get rid of the pheo. They need surgery. So what do? And I don't know if there's a sim this time on pheos. She changes them up so much. But if you haven't had sim yet and it is on a pheo, you're going to get this question right, I bet. So what do? There's surgical removal. And the treatment is alpha and beta adrenergic receptor blockers. We do alphas first. Just think it starts the alphabet. Because alpha blockers are going to dilate the blood vessels. If we gave betas first, you're decreasing heart rate, they have a hypertensive episode, you're going to cause a hypertensive crisis. So we give the alphas first, get the vessels nice and dilated, and then we start the betas, decrease the heart rate. So I don't know if that's a question even she'll ask you, but that's pretty classic for treatment of this. All right, if surgery is not possible, we go to Dempsor. Dempsor is metirazine, and this decreases catecholamine production by the tumor. It's the best we can do for you in the moment. And when you see someone with this who is absolutely terrified, you will realize how grateful they are to get the Dempsor if it's going to stop that. Okay, what are you doing? Assess your patient. This person comes in to the ED, and we know it, we suspect it's a pheo. When they come up to you on 6th floor or wherever they are, and they have an episode, you will know it. They have that pounding headache, tachycardia, that they think their heart is going to jump out of their chest, and they're soaking in sweat. And they're not back on the bed unconscious. They're usually in a panic state running for you. So you see this, I mean, it's crazy. Now, watch their position changes. Pre-op, we've started the alpha blockade first. Then we do the beta blockade. So now this person's getting up out of bed. You have to be sure they don't get orthostatic. Be careful of that. We have to teach them that because they're used to just getting up in a panic, and it could change their pressure some. All right, so what else do? We watch the blood glucose. We give them emotional support. They are terrified. When I tell you terrified. And, you know, we tell them, we avoid palpation to the abdomen. We don't want to put any pressure on the adrenal. If the tumor's hanging there, we don't want to stimulate anything. Check the vital signs. Hypertension can still remain after surgery. They're not sure why, but it does a lot of times. These people, these poor souls, feels are terrible. All right. Pancreas. This one, oh, I'm sorry. Does someone have a question?
Yeah, when you're giving them the alpha and betas prior to surgery, is that just to prevent them from going into an episode in surgery? Because that's not like our first line when they're having an active attack, right?
Right. We're doing this because we have to get this situation under control before they can go in and be a candidate for surgery. So how do we get this BP down? You know, we have to do the alphas first. And sometimes it's alphas for 2 days and then they'll start a beta. Sometimes it's alphas for a week the doctor wants, and then the beta starts in, and then the surgery. So it can be a longer process. In the meantime, we have Demser, which hopefully is stopping those episodic reactions that they're having that terrify them so much. But yeah, they won't qualify to go to surgery with the kind of hypertensive episode they have unless we get the BP under control. Yeah.
Okay.
Okay, so here's your pancreas now. I know this one always moves fast. Usually people say to me, we've had this, but we have to review it, you know. So here's your pancreas, and it runs along the back of your stomach. And, you know, you have your alphas and betas, and, you know, you got all your different cells in there. Probably, you know, the betas most because that's where your insulin comes from. But your somatostatin comes from here, polypeptides, all of that. So we cover two main conditions. We cover DKA, which you probably had a little bit about in 151 maybe, and we cover HHS, which is not covered elsewhere in the program. All right, so DKA, this is most commonly seen in type 1 diabetics, and it's a deficiency of insulin, and it's either illness or infection or poor management or non-compliance, but the body cannot utilize its glucose. So what happens? You have hyperglycemia, you have ketosis, you have acidosis and dehydration. And people die of DKA. They do. And I know students have said to me, I was on, I don't know, pick a floor, 7 tower, 6 tower, wherever they were, and they said a patient had DKA, and that patient was up and walking around. That patient was also already out on the floor. When someone comes in with a true DKA, they're managed in the ICU, and from the ICU, they go out to the floor. So that admitting diagnosis stays with them, but that's not the crisis they were in. So what's the insulin deficiency? Well, glucose cannot be utilized by the body in this state. So the body begins to break down fat as a fuel source, which gives you a ketosis. The ketones are the fat breakdown. It's going to alter your pH, and it puts you in an acidotic state. So the ketonuria you get if we're checking your urine, I mean, if someone's an established diabetic and they have kidney involvement, their urine wouldn't be accurate. But if we're checking urine, just dipping to see, that's why we see ketones in the urine, because the body's just trying to get rid of this ketosis any way it can. And the electrolytes are depleted, because when you have high glucose, you have an osmotic gradient. So the person is peeing and peeing and peeing, and they're dehydrated. They lose a lot of electrolytes. All right, so what else happens? Well, the insulin insufficiency is going to impair your protein synthesis, so they get nitrogen loss from protein breakdown. The osmotic gradient I talked to you about that further depletes everything. The patient can end up in renal failure if this is not corrected. A lot of patients die from DKA. Just because you might have seen patients who survived it, that's great. You don't see the ones that don't make it from the ED up to the ICU. You don't see the ones that don't make it from the ICU out to the floor. People die of DKA. It's dicey. All right, so what do you see? Well, the patient presents with a high glucose. Lewis tells us up over 250. It's probably over that. I know she's thinking 250 is, oh, that's high. It is high, but I've seen them 450 higher than that. Okay, so they get tachycardic, they have orthostatic changes, lethargy, weakness, confusion. These people are stumbling. Sometimes their family thinks they're having a stroke and brings them into the ED. They could be vomiting. They have an appetite and daze. Maybe they've had a throwing and going thing, and that started all this because they haven't been eating. They don't take insulin. Sugar gets out of control. They have those Kussmaul respirations. You all know about Kussmaul respirations. What are they? Who can tell me Kussmauls? Anybody?
Very fast, deep breathing.
Deep breathing. Yes, they're trying to rid the body of the acidosis. They have that acetone kind of breath. It's a very different smell, very different smell. And you won't know until you smell it and you're like, oh, that's what she meant. Okay, so what are the diagnostics? We do serum labs. And I mean, you are married to the lab. If you have someone in DKA with the endo tool, it's constant. So we're looking at sodium and potassium and chloride and bicarb and BUN, and they're looking at anion gaps, which typically they get off of the ABG now. We don't have to do the formula anymore. And we're looking at serum osmolality to establish this patient's fluid balance status and how we can correct it. And then they can test the urine for ketones if your kidneys are in good shape otherwise. They can test your urine for glucose and see if you're spilling out. And your specific gravity, it's going to tell them something about your osmolality of your urine. So that's good too. All right, so the interprofessional care depends on the severity. Typically in the hospital, they're in the ICU, and it's very dangerous. They give them short-acting insulin, sometimes a bolus first, and then they start IV fluids with an insulin drip. And we have to be very careful. They use half saline or normal saline, and they do very, very slow doses of insulin in the insulin drip. It's 0.1 unit per kilogram per hour. Very, very slow. We check them constantly. We don't want to bring the blood sugar down fast. We take it down very, very, very slowly. As it's coming down, when it gets to about 250, we add D5 to the bottle. Now, instead of normal saline, it's D5 normal saline. Instead of half saline, it's D5 and a half. And insulin too. But we can't let the sugar precipitously keep dropping. So you have to be very, very careful. Okay. What else? You can have, if you have the wrong fluid or we don't correct it right, the risk is always cerebral edema. We talk about how fluid chambers try and balance themselves out. And if they balance by shifting into the cell, they're going to cause swelling. We see that in cerebral edema. So it's a dangerous thing. Okay, so what else? Well, watch the cardiac patients for fluid overload. Patients in the ICU will probably have a central line. Sometimes if they go straight to the floor, if they get them regulated enough, caught them in time, they don't need an ICU bed, and they send them to the floor, they might put just a central venous pressure line in. But we have to watch them for fluids because we're restoring so much fluid in the body from the dehydration. There could come a time when you go the other way, and now we could put them into failure, especially if they're cardiac patients. So you got to be careful. We keep them on EKG monitoring, and we're going to replace what we need to. Typically, your potassium replacement is constant, runs of K and runs of K. And what you'll find is, I think I've mentioned this before, if they're giving a lot of runs of K to somebody, they'll throw in a magnesium, even if the levels are normal, because it helps stabilize your potassium. So the INOs have to be good, track your INOs, watch your glucose levels, insulin to correct hyperglycemia and the hyperketonemia, because it will straighten them out. We get a K level before the insulin begins, because insulin can drive K into the cell. So it depletes it from the blood. So, you know, it's got to be at least 3.5. We start running K. Okay, regular insulin is correcting, like I just said, the glucose and the ketones. That'll be good. Small doses, we're talking 0.1 units per kilogram per hour. A rapid drop is going to cause fluid shift. That's not what we want. Insulin allows water and potassium into the cell. So in the blood, then, we're going to have hypokalemia. We got to watch this. Their mental assessment is wonky because why? your brain needs glucose to function. And you have high glucose, but it's not, the body's not utilizing it. It's not where we need it. So their brain is all over the place. They're not reliable for sure. And it scares family big time. Okay, so HHS is similar, but a little different. This is hyperosmolar hyperglycemic syndrome. This we see in type 2 diabetics. So it's also a life-threatening condition. Type 2 diabetics like to think of themselves as just taking a pill, not insulin, so I'm not as sick. But this can make them as sick for sure. So what happens? They have enough insulin that they make, so they're not in DKA, but it's not enough to stop them from being in this hyperglycemic state. They have, with high glucose, you're gonna have that osmotic gradient, so they're diuresing like crazy, and they get ECF depletion, so they get dehydrated. So we see it in type 2 diabetics. We see it in non-compliant type 2 diabetics especially. We see it in people with type 2 diabetes that maybe are compliant, but have a huge interruption to their homeostasis. So they have a bad urosepsis, or they have, some major trauma or something like that. So we always have to be watching for that. Maybe they have a pneumonia that makes them go on a vent or something. So it's a big enough insult to the body that it throws everything off. Okay, so fewer symptoms, less of an insidious onset. It's the presence of some insulin that's saving them to some degree. But they do have a profound neurochange. They will have this confusion, or they get up and they're ataxic, or they're falling all over, or they could just be having seizures. One guy in the back of church one day pre-COVID just was having a seizure on the floor, and they found it was HHS. So it's just that patient, how they're going to respond to what this is. I told you before, it can be mistaken for a CVA. So typically EMS comes on the scene, they'll snap a blood glucose and see, just for a frame of reference. It's just one of those quick little things they do. But typically there's a history of poor intake. They didn't feel well. They weren't hungry. They were peeing a lot, didn't recognize that as a contributing piece of the puzzle. Maybe they're depressed. They're a non-compliant diabetic because they're depressed, they're diabetic, and they had a friend who lost legs or something, and they're not seeing their, what is their controllable situation with somebody who was uncontrolled and had all the sequelae related to type 1. So they need support and they need education if that's the case, if it's non-compliance. Okay, anybody that has to go can. I'm just going to finish these last few slides so we know the tape is intact, but I don't want to hold you past your time. So you can feel free to leave. So anyway, the blood glucose elevation here, Lewis is telling us, is up over 600. And this is true. I've seen people 700s, 800s come in with this. Yeah, dangerous. So they have an increased serum osmolality. Why? Because they're dehydrated. They're peeing and peeing and peeing. So what's left in the blood is solute. So they're negative for ketones because they have enough insulin that they don't have ketones. They're not in a ketotic state. That's the difference between your DKA and your HHS, the prevention of ketosis. Might not save them, but that's a big, big difference. Okay, medical emergency, we treat it similar to what we do for DKA. They're gonna have IV fluids, half saline or normal saline. HHS needs more fluid replacement, and you have to watch people with type 2 diabetics tend to be, middle-aged or older, maybe a little bit overweight, probably comorbid, and probably are cardiac patients already to some degree, hypertension or angina or something. So regular insulin by slow infusion. First, they have it, that sometimes they'll give a bolus, a little bolus of it, then they start the drip. It's insulin in the IV bag. When the sugar gets, again, about 250, they're going to switch the bag out with the insulin and the saline to be running with the D5. We don't want it dropping that much. Hypokalemia is not as significant, but we still watch it with the EndoTool and we replace it as needed. And it's frequent labs. It's going to make you crazy, the EndoTool. You're up every 15 minutes, it seems, doing something. Okay, so what do? Assess your patient, Monitor the lab, stay on top of the endo tool. The alarm will go off and tell you something else is due. Check this, check that, get up and do it. Watch the IV fluids, watch your IV sites. You need access sites. If it's a wonky IV, pull it and get a good one. Check your neuro checks for level of consciousness changes. Watch for hypovolemic shock when they first come in, but then as we're replacing all this fluid, watch that they don't go over that line into overload, especially if they have cardiac history. You know, that's a big deal. Okay, so then we talk about hypoglycemia, which I know you all know, and you've been taught this because you have to know for being in the hospital, you know, what we do for patients, what the protocol is, but let's just cover this. So hypoglycemia, significant drop in your blood sugar. Some people are very sensitive to it. Some people hit a sugar of 60 and they're like, you know, symptomatic already. Some people go to 30 and at 29, they're gone. But at 30, they're still talking. It's hard to know. So when your blood sugar drops below 70, your neuroendocrines are activated, your neuroendocrine hormones. So your epi and your norepi, right? Your insulin supply is suppressed. The body's in trouble. The blood sugar's low, suppress the insulin. The body tries to produce glucagon because if it can do that, it can convert it in gluconeogenesis and give you sugar. But your metabolism is slowing down if you're getting into this hypoglycemic state, so it may not work. Epi gives them the shakes and the palpitations and the diaphoresis they have when you see them. And it makes them anxious because they can tell something's going on. The brain requires glucose. The less glucose they have, you see it in mental changes. All of a sudden, they're like, they think they're in the park, or they start calling someone who isn't there, or whatever. Someone coming into the ED or being picked up on the street, it can mimic that they're drunk. And so what do? They check a glucose. It's an easy way to just see that it's this and not that. All right, so there's such a thing called hypoglycemia unawareness. I think this is important. I have to point this out to nurses on the floor all the time. They'll ask me, they'll stop and say, Jane, what is with this guy ordering this? Some patients have little or no symptoms until the blood sugar is very, very low. I told you, they can get down to 30, they're still talking, 29, they're unconscious. You know, really, literally, the 3, 4 points, they're gone. So they're suddenly incoherent. Suddenly have a lot, and the nurse was just in the room. The patient could have been 40, and they're doing fine. The nurse wouldn't suspect a thing. She walks out and comes back in to bring a Kleenex. The patient's out cold. So there's increased risk for the elderly, and especially people on beta blockers. If we're giving you a beta blocker for your blood pressure, your heart rate, whatever we're giving it to you for, remember the action of a beta blocker. It dulls the beta response. It's going to slow down that response that increases your heart rate and causes all that. So it's going to hold off that epi-norepi a little, right? So in people who are on beta blockers, the doctors are usually okay with their sugar being 120, 130, because they don't want, knowing this patient isn't going to respond until the blood pressure is super low, because we're giving them a drug that's holding it off. They'd rather them have a cushion of blood sugar than to always find them symptomatic of low blood sugar. So they may order coverage, and it's to start at a higher sliding scale than anybody else. And nurses will stop and they'll say, you're a teacher, tell me how this guy does. Why does this girl always come in here and order it like this? How stupid. I called them to say the blood sugar is 125 and they said, fine. And I said, are they on a beta blocker? Well, yeah, okay. But what does that have to do with insulin? Well, nothing to insulin, but what is the beta blocker doing? So think about that. And I don't know why I wouldn't have the doctor on the phone say, really, that high? You know, and have the doctor explain it. But for whatever reason, they don't. But it drives nurses crazy. So think about this. This is a common thing you see in an older population. You know, the older person cannot withstand a big drop in blood sugar. And if they're asymptomatic till it's all the way down low, they might not come around from it. So if they're really elderly, the doctor allows them a cushion. Certainly if they're on a beta blocker, we have to take into account what the beta blocker is doing to that response, okay? All right, hypoglycemia can also happen when you have a high blood sugar and it falls precipitously. Even if it's not down in the 30s, if it's dropped too fast. We go very, very slowly dropping the blood sugar. Okay, so some is related to poor diet, some it's management of food, some it's, just teaching people compliance. This is how you have to eat. This is how you have to check your blood sugar. Take your doses regularly, set alarms, whatever it is, we have to get people to be compliant. It's a shame for someone out of non-compliance to get this potentially ill and possibly die because they're just not understanding how to regulate their situation. So we can help with that. So the interprofessional care is the rule of nines that they do at the hospital. I'm sure you've had it also in class. Blood sugar less than 70 and the patient's conscious. They tell you to go with the fruit juice and soft drink, something like that, a fast-acting carbohydrate. Check it in 15 minutes. If it's still under 70, then you have to up the 15 grams of carbohydrates and recheck them again. If it's stable, you're good. You give them the carbohydrates and protein and all of that. If not, you got to get a doctor involved. Now, in the hospital, the rescue will be D50 in a syringe. The patient has an IV access and their sugar is low. If I can't be sure someone is completely coherent with me, nothing goes in the mouth. The other thing we can give them, it's probably on another slide, I always get ahead of myself. The other thing we can give them is glucagon. And that's an option. Some people like to do that. But think about your patient. If they're already symptomatic, the body processes are already slowing down. And now I'm giving them glucagon, which not only does it have a strong visceral response, so it tends to make people nauseous and all of that, but I'm relying on it being absorbed through the muscle, getting to stimulate the liver to do this gluconeogenesis and give me sugar. That's relying an awful lot on someone's metabolism who's otherwise comorbid and who's in a situation where they're hypoglycemic. So what do? We go to the Omnicell, we take out a D50, they screw this big barrel syringe, you bring it to the IV and push it, and the person comes alive like a marionette. I've been in the room with a student when the sugar is like, they'll come out to me and be like, Jane, the sugar's 36. And I'm like, what is your patient like? Well, they're sweaty and they're this and that. Okay, let's go. And I get a D50 and I go in, I talk to the patient and they're looking at me half, their eyes are rolling or whatever. And we give them even half of it in the adapted IV. And all of a sudden they open their eyes and they're like, hello. I'm like, hi, this is my student. She brought me in to help you. She thought you needed our help. And they look at me, isn't she sweet? She's lovely, and they're just all of a sudden back like they're from the dead. So, the D50 is a better rescue in the hospital because it's going to bring them right back. We're not relying on the patient's own metabolism to do something to help them when the metabolism's slow. And we're not relying on them taking something by mouth that they could aspirate on. Glucagon, I've seen more patients vomit from it. That also increases aspiration risk. If it was all I had, I'd go to glucagon. If I have D50, it's D50. And in the hospital, that's what you'll see. Okay, so what else? Assess your patient. Vital signs, oxygen, we meet all their needs. What are they doing? How are they? What is their O2 sat? Let's look at the monitor, what's going on. Neuro assessments. If they've had trouble with blood sugar, their neurofunctioning can be off. Do the labs. You will be married to that endo tool. I'm telling you, if you've had nothing to do with the endocrine tool yet, and you see it in preceptorship, you'll know exactly what I mean. Urine ketone testing, if they order that. Typically when patients are sick or in the ICU, they don't. But keep your lines functioning. It doesn't help you to have a line that doesn't work. We need access. And CVP monitoring if they're in an ICU that can accommodate that. So what else? Patient education. Remind them on sick days, they still have to watch blood glucose levels. Drink fluids every hour, even if they can only drink 30 cc's at a time. Get some fluids in. Small meals frequently, but small portions of carbohydrates regularly. They have to understand their dietary need to know what that is. Take their insulin as scheduled as long as they can take some fluid and regular carbs. If they're too symptomatic, If this person is just throwing and going and can't stop and is not going to be sipping water and eating small amounts of carbs, they need an ED. They need to go where someone's going to give them an IV, or they'll be in DKA or HHS. If they really have a throwing and going and they can't keep up with their insulin or their antihyperglycemic needs, their sugar is going to go out of whack and it goes downhill. So they're better off going and getting medical attention where we can give them an IV and get their fluid status regular. Anybody, not just diabetics, anybody in your lives, if you have a bad throwing and going that you are miserable, and I mean, you've had them sometimes, I'm sure, where you're just laying there like, oh, kill me now, you know, it's awful. Get yourself to an ED. You would be amazed what a bag of fluids can do for you. They start infusing fluids and all the symptoms go away. So don't stay at home or let your loved ones stay at home and dehydrate and just be miserable. It's not easy to get to the hospital, I'll grant you. They bring buckets, they sit on towels, they're miserable. But if you can get there, they'll take you in and put an IV in you and it all gets better. Hydration is wonderful. So that's just a little something to keep in the back of your head. So thank you for your attention. Sorry this went over. Usually it finishes on time. I don't know why it went over, but maybe because I had to fix my cords earlier. I don't know. But anyway, if you have any questions at all, reach out to me. And if I owe you a response back, I have not forgotten you. We are Zooming what seems 24 hours a day. And so I am a little bit behind on my responses and emails, but I'll catch up while Jamie's talking. Okay? All right, guys.
Thank you.
All right.
Thank you.
You're
Thank
welcome.
you.
I'll get it up as soon as possible. I want the other one to finish. Thank you.